Keitan, ladies and gentlemen, I'd like to thank the Society for allowing me to present our work today. And hopefully we have the video. These are my disclosures.
67 years old woman.
You can kill the audio, please.
Systemic lupus, steroid-dependent.
You can kill the audio.
Dysphagia.
Thank you. This patient is a 67 years old woman with a history of lupus, was dependent on steroids, who had a history of dysphagia and recurrent pneumonia, who presented to the emergency room what initially was thought to be hemoptysis and underwent bronchoscopy, which was negative. The upper endoscopy instead showed two large esophageal diverticula that then they were addressed diagnostically by a barium swallow. The patient was stabilized and taken to the operating room for laparoscopic exploration. She received 4 units of blood at this point. The dissection started in a standard fashion on the hepatogastric ligament and then proceeded through the phrenoesophageal membrane to the left. Using a harmonic scalpel, the left crus of the esophagus here was freed up into the mediastinum. This part was fairly straightforward with no significant adhesions. At this point, the dissection continued in the posterior mediastinum, dissecting again behind the esophagus once the crura, both left and right, were exposed. At this point, the tunnel behind the esophagus was created, and Penrose drain was inserted to help with the retraction of the esophagus. The patient is positioned in standard fashion for a Nissen or a Heller myotomy. The surgeon is standing in between the legs, and this is a 5-trocar approach. Once the Penrose is inserted, the esophagus is retracted inferior laterally. This is the diverticulum on the left side, which was smaller, as shown on the upper GI. The dissection of this diverticulum was somewhat easier. The adhesions were flimsier, so most of this dissection is actually done bluntly. The diverticulum is completely freed up to the upper extreme. On the right side, the dissection of the diverticulum was more complex, and that's the side where the bleeding was occurring from. We inserted an endoscope, and by transillumination, we defined the extent of the diverticulum, especially the upper portion. The dissection here on the right side required more energy to separate from the adhesions circumferentially into the mediastinal area. Once the diverticulum was completely isolated, a linear endoscopic stapler was inserted with absorbable staple reinforcing material of bovine pericardium. 2 firing of the staplers were necessary to come completely across this diverticulum, which was approximately 5.5 centimeter in size. This is the second application of the linear endocutter. At this point, the diverticulum of the right side was placed in a specimen retrieving bag. The diverticulum on the left was stapled in a similar fashion. Because of the smaller size of this diverticulum, a single application of a linear stapler was necessary. The application of the stapler was done with an endoscope in the esophagus, making sure that the entire mouth of the diverticulum was covered. A leak test was done afterwards to make sure there was no evidence of leak from the staple line. At this point, an anterior myotomy was performed, and then a partial anterior fundoplication was performed. Of course, the options here include also proceeding with a posterior fundoplication. This is the left side of the myotomy, suture to the gastric fundus. As far as fundoplication concerned, I don't think there's any doubts at this point that it's necessary, not only because the phrenoesophageal membrane is completely destroyed, but also because the myotomy is extended down into the stomach. And the reasoning behind that is to prevent a recurrence of the diverticulum, but also an increased chance of a staple line leak and ultimately to reduce what the initial symptoms might be if there's an associated motility disorder, like it's in the most cases of epiphrenic diverticula. This is the completion of the anterior fundoplication. At this point, fibrin glue is applied around the staple line on either side, and JP drains were inserted. There were no intraoperative complications. On post-op day number 1, gastrografting followed by barium swallow was performed that showed adequate myotomy, no staple line leak, and prompt emptying into the stomach. The diet was started on post-op day number 4, and the patient was discharged. The patient was readmitted 10 days later with fevers and right lower lobe pneumonia and a pleural effusion that required percutaneous drainage. There was no evidence of staple line leak on a repeat upper GI, and the percutaneous drainage completely resolved their symptoms. And she's asymptomatic now at 10 months follow-up. Thank you very much.